Hi, everyone. Thank you for having us. We're really excited, Sarah and I, to share our work on the DASA with you all. It's been a journey for us. So our objectives today, we hope that when you leave here, you're able to explain how to use the DASA tool, how we designed our study and analyzed the results, and what tools we could potentially use to predict aggression in the medical surgical population. So our journey began back in April of 2014. At that time, our local state civil secure treatment unit closed. This was a unit that accommodated patients with severe mental illness that had more potential to become violent that local hospitals were unable to manage. So that burden was placed on the local community hospitals to manage these patients. It was also better for the patients to be treated locally where they're close to their support, their families, versus being transferred to the other state hospital, which was several hours away. We reviewed our charts and reviewed the data, and we did note that 20% of our inpatients on our adult unit at St. Mary's Hospital engaged in verbal or physical aggression. We also noted that in the first half of 2015, our restraint and seclusion rate increased. It tripled. We knew we had to do something. At the time, nurses were assessing for risk of aggression using clinical judgment alone, and we knew we needed to do something different. So we came up, we looked at different tools, and we decided we would do a study evaluating the DASA tool. The DASA tool is a dynamic appraisal of situational aggression used to predict aggression in the next 24 hours. We chose this because it can be completed in a matter of minutes. It's more reliable, studies have shown, than in predicting aggression than clinical judgment. We had not found any studies validating it within the United States, only in Australia and Europe. We reviewed, the team decided we would move forward with this, and we did receive permission from the creators of the tool to move forward with our study. And I apologize, this is the DASA tool, and I know you likely cannot see, but basically the DASA tool is a 7-item structured tool, and it assesses impulsivity, irritability, unwillingness to follow directions, sensitivity to perceived provocation, easily angered when requests are denied, negative attitudes, and verbal threats. And so nursing staff would go through each of those items and give a patient a score of 0 or 1, and they would total the score from that to determine the level of risk. So based on that score, staff would determine the course of action. So a score of 0 to 1 indicates a low risk. A score of 2 to 3 indicates moderate risk and the need to monitor the patient a little bit more closely and consider some interventions and additional safety measures. And a greater than 3 indicates a high risk. So with our study, our nursing staff were educated on the tool, and they completed the tool daily. We asked that they completed it by 10 a.m. The reason for that is we wanted to ensure that we captured a true assessment of potential aggression without any interventions such as PRN medication. We then reviewed the chart after we did the study and compared the DASA scores with documented behaviors of aggression in the subsequent 24 hours. And then we also looked at charts. We did a retrospective audit of charts comparing patients who were deemed at risk for aggression based on clinical judgment and whether they acted out in that aggression. Thanks to our colleague, Chris Baker, we were able to analyze our data using the ROC curve. And I'm going to talk a little bit about that just so you can understand what this test is. The ROC curve is a receiver operator curve used to analyze the data. It's not a test of statistical significance. It's a visual and mathematical model to express the combination of sensitivity and specificity on a scale of 0 to 1. The x-axis, as you can see, is a specificity or rate of false positives, and the y-axis is sensitivity or rate of true positives. The green line represents essentially a worthless test, or the ability of the tool to discern between true and false positives would be equivalent to tossing a coin. The closer to the upper left border, the more accurate the tool is. So the blue line towards the upper left border was our data analysis. The area under the curve, or AUC, measures performance of the test. This is the area that you see under the blue line. It is represented by a numerical value that identifies how well the tool can decipher between true and false positives. An AUC of 1 represents a perfect test. A score of 0.9 to 0.99 represents an excellent test. A score 0.8 to 0.89 represents a good test. And an AUC of 0.5 indicates that the predictor is no better than chance. The AUC for our study using the DASA to predict aggression in the adult behavioral health population was 0.897 with a confidence interval of 0.817 to 0.977, indicating that the DASA is a good to excellent tool for predicting aggression in the adult behavioral health population. Furthermore, we learned that only 6.4 of patients identified as risk for aggression using clinical judgment actually did go on to engage in aggression. With the DASA tool, however, we saw that only 2.1% of patients identified as low risk for aggression engaged in aggression. 67% of moderate risk patients exhibited aggression, and 80% of high-risk patients exhibited aggression. So this really speaks to the specificity and sensitivity of the DASA tool. It really allows you to hone in on those patients you really need to focus your efforts on. So we incorporated this tool into our practice now. We assess patients daily using the DASA tool. If someone is scoring on the DASA tool, we all know it. We're communicating in our daily interdisciplinary rounds. We're proactively having medications available for symptom management. We have security rounding on the unit. Especially if we have someone that's scoring moderate or high, we have them round more frequently. We're communicating with them, informing them of a patient who may become potentially aggressive. We've also will move patients obviously closer to the nurse's station. We have also collaborated with occupational therapy, and that's something we're also very excited about, incorporating sensory modulation therapies to help our patients de-escalate. Studies have shown that this is effective not only for kids on the autism spectrum that you see in the schools, but also for people suffering from mental illness and anxiety. Rocking chairs are actually one of the most effective, longest lasting sensory modulation techniques. So we have multiple rocking chairs throughout the unit, weighted blankets, hand fidgets. And our outcomes. This graph here illustrates our restraint and seclusion data. So, the blue line is our restraint data, and as you can see where that arrow is when we incorporated the DASA tool, and you can see a significant reduction in our restraint and seclusion since incorporating the DASA tool.
In April of 2018, the Joint Commission issued a Sentinel alert requiring that hospitals have the following things in place, and those are listed on the slide above. As Christina spoke to, we found out that about 20% of our behavioral health patients were acting out in aggression. We conducted the DASA tool and studied the tool in hopes of being able to better predict those patients who would act out in aggression, and hopefully better be able to protect our staff and protect our patients as well. We did validate this tool, as Christina spoke about, but we know that violent events are not isolated to the behavioral health population. Healthcare workers across the world are at high risk for being a part of an aggressive event. And we know that up to 38% suffer from physical violence at some point in their career. We essentially replicated the study in the Christina and I recognized an increase in violent aggression events at St. Mary's outside of the behavioral health population. Because of the promising results of our previous DASA study, we wanted to test this tool's predictive validity in the general medical inpatient population as well. We essentially replicated the study from the behavioral health population. We chose to study the tool on our adult medical respiratory unit, which had experienced a significant increase in violent and aggression events in the last 2 years. We were also interested in this unit because we knew there was a higher incidence of patients with delirium. We do know that with delirium, it is difficult to predict. It waxes and wanes, and the mechanism behind these patients acting out in aggression is very different than a patient with a psychiatric illness. So we wanted to see if the tool was able to predict aggression in these types of patients. When we first started analyzing the data after collection, we recognized in reviewing the charts that the RNs were not typically documenting verbal or aggressive events. We asked them to document the DASA score, as we did with the behavioral health population, but we didn't specifically talk about documenting those events that took place when a patient actually acted out. And so when we first collected the data back in March, we looked at it, the charts, and recognized that these events weren't getting documented. So we knew that our results weren't going to be accurate. So we ended up recollecting the data in April. In order to get nurses to document these events, we did some education with the 8 Southwest staff. We had developed a smart phrase for them to document the DASA score, so we could track that. We added a piece where the nurse could document any aggressive events. So it would be all in one place, and it would send a reminder to them to document those events as well. After recollection of the data, we found some interesting things after analyzing it. We observed that many of the cases that resulted in verbal or physical aggression were in patients suffering from delirium, which was not the case in the behavioral health study. We know that delirium is difficult to predict, as I said, so it was interesting to see this in our results. We put our data through the ROC curve, as Christina explained a little bit earlier. As she outlined, the area under the curve, or the blue line, measures the performance of the test. The AUC for the predictive validity of the DASA in the medical population was 0.484, with a confidence interval of 0.309 to 0.659. So this AUC indicates that the tool performs no better than chance alone in predicting aggression in the medical population. This was not vastly surprising to us, given the amount of delirious patients we saw in this sample size. I'll hand it back to Christina.
So we were a little disappointed that the DASA didn't work for the adult medical population, but again, like Sarah mentioned, not surprised. So our recommendations based on this study is that we limit the DASA tool to only adult behavioral health populations. There's also other tools out there, and we quickly, that was kind of our next step. So what else is out there that could be our next study? There are several other tools that have some promising results in predicting aggression in the medical population. Excuse me. One of those being the ABRAT, which is kind of a combination of the STAMP and the M55. Alone, the M55 has had mixed results. So that'll be our next course of action to see if one of those tools would work for that population. And also exploring the need for, we need to see if the DASA could work in the child and adolescent behavioral health population. There's a need for a research study to validate that as well. Thank you.